Hello everyone, and welcome to the webinar, Traumatic Brain Injury Among Service Members and Veterans, What Behavioral Health Providers, Families, and Peers Should Know, sponsored by SAMHSA's Service Members, Veterans, and Their Families Technical Assistance Center. My name is Samantha Holcomb, and I am a Director of Practice Improvement for National Council for Behavioral Health. I will be serving as your moderator this afternoon. Before I begin, I'd just like to draw your attention to some important webinar logistics. During today's presentation, your slides will be automatically synchronized with the audio, so you will not need to flip any slides to follow along. You will listen to audio through your computer speakers, so please ensure they are on and the volume is up. You may send us questions at any time during the webinar by typing your question into the Ask a Question box on the lower left portion of your player. Depending on the question, we may type back an answer or save it for the end. We'll answer as many questions as time allows. This webinar is being recorded, and an audio version of the entire webinar as well as a PDF of the presentation slides will be available on the Webinar Archives page of the National Council website within 48 hours of the broadcast, as well as circulated to participants. Following the webinar, we invite you to please complete a brief, short survey. Finally, if you need technical assistance, please click on the question mark button in the upper right-hand corner of your player to see a list of frequently asked questions and contact info for tech support if needed. I'll now pass things off to Catherine Power.
Thank you very much, Samantha. We'll go to the next slide. And this is a disclaimer for SAMHSA, CMHS, and the Department of Health and Human Services. We'll go to the next slide. I want to welcome all of you today to this very important seminar relative to traumatic brain injury and the service members and veterans population. I'm Catherine Power. I'm the Regional Administrator for Region 1, which is the 6 New England states, and I also have the opportunity and the pleasure of serving as the Senior Executive Lead for service members, veterans, and their populations at SAMHSA, and have been doing so since 2005. Next slide. One of the things that we do at SAMHSA is that we very much want to work with our other federal agencies, our federal brothers and sisters, and particularly in staying focused on this population. There is no mandate, there is no authority, there is no appropriation, basically, that Congress gives to SAMHSA to work with this population. So why are we involved in this? Well, we're involved in it because we think that the behavioral health of this population is an important, urgent, acute matter, and it will be an important, urgent, long-term matter for many, many members of this population. So we have developed a series of partnerships and collaborations with both the Department of Veterans Affairs and the U.S. Department of Defense. And in many cases, SAMHSA acts as the partner representing all of the Department of Health and Human Services in a lot of activities, whether we sit on blue ribbon commissions or we are acting as partners under executive orders that dictate us to work with each other on behavioral health issues. We see this collaboration as essential to the work of HHS, to the work of VA, and to the work of DOD. So we're very fortunate that we have established and will continue to cultivate those relationships across departments which help us deliver to you good information and help our grantees and our states have some ownership for this population. Next slide. As you all know, SAMHSA has developed Service Members, Veterans, and Their Families TA Center, and they have been a key partner over the last several years in terms of maintaining and strengthening our ongoing collaboration between military and civilian stakeholders. We often find when we talk to the civilian community that they have the assumption that DOD and VA will take care of these individuals, and in fact, that is not the case. When people leave active duty, they no longer participate in DOD programs, and in many cases, people may or may not choose to involve themselves with VA services. And so if they're not using VA services and they need supports, they will go out to their community providers. The community providers are the civilian providers within states and communities that in many cases SAMHSA funds through their state mental health or substance abuse authorities. Our TA Center is really a centralized mechanism for all the providers, all of the cities, all of the states, all of the regions to learn about this population, to connect with active duty assets and VA assets in their region, and to share best practices. We also see our role at the TA Center of making sure that the civilian population knows about military and VA resources, and that the active duty military and VA know about the community resources. And I think it's a very important bond that we are trying to build across cities and towns and states and local communities to make sure that there's a coordinated response. And in fact, much of our work at the TA Center is to encourage cities and states to really take ownership, to understand that this population belongs to them just as assuredly as it belongs to either VA or DOD. And we want to be sure that those community providers, one, have a knowledge and are culturally competent about military populations, and we also want to be sure that they're implementing the promising and best and evidence-based practices. And in many cases, that means being familiar with trauma and understanding what trauma-informed care involves. And I'm sure our presenters today will be talking about that. SAMHSA has been the lead in looking at how trauma affects individuals with mental illnesses and substance use disorders, and in many cases has been a part of their life experience. And that is certainly the case for this population in terms of combat, in terms of other military experiences. So just understanding trauma and the resilience necessary to overcome trauma and to heal with the trauma experiences and other debilitating and disabling experiences is really part of what we're going to talk about today. Next slide. So one of the things that we've done in SAMHSA is that we have asked each of the centers across SAMHSA to help support the TA Center. So for the first time this year, we have financial support for the TA Center from the Center for Mental Health Services. We're doing work with them on recovery and building recovery and advocacy. The Center for Substance Abuse Prevention, we're doing work with them on Talk, We Listen, which is about underage drinking and working with families about alcohol use. And the Center for Substance Abuse Treatment, in which we're talking a lot about the appropriate evidence-based practices for combating the opioid epidemic, and in fact working on looking broadly at addictions, and frankly with CMHS and CSAT looking at the co-occurring conditions of psychological distress or mental illness and addictions and substance use disorder. And then finally, this year, we're very fortunate that the U.S. Department of Veterans Affairs is also supporting the TA Center in helping us do a variety of initiatives, most specifically the Mayor's Challenge. We're going across 20-plus cities to get mayors involved in understanding and appreciating the needs of this population and looking specifically at suicide prevention and at treatment and prevention services. Next slide. And you can see from the map that we have had a variety of different policy academies and implementation academies. Policy academies are the vehicle in which we either go physically into the state or the state comes to us at headquarters with a team that's committed to defining a strategic plan for outreach and engagement for service members, veterans, and their families. And you can see that we have really, across the United States, had the opportunity to work with all 49 states in terms of either a policy academy and or an implementation academy. And some of those policy academies were the origin of the civilian community working with their state and regional counterparts in DOD and VA, and some of the implementation academies looking at specified topics like employment for individuals who are service members, veterans, and their families, homelessness issues, suicide prevention issues, et cetera. And so looking across specific topics that are that this population is affected by. So we continue to do this work, and every day and every week and every month and every year we're interacting with the policy academy teams across those 49 states. Next slide. And we have a lot of resources. So of all the things today that I'd like you to remember, I'd like you to know that our TA Center has tremendous technical assistance resources, and we deliver those resources to the states at their request, and we deliver those resources to the Policy Academy teams, And you can see the distribution of what we're doing. We're working with some states on a crisis intercept map, which is a methodology for diverting people from the criminal justice system. We're working with the VA Mayor's Challenge Project. We're working on the CSAP Talk They Hear You, the Policy Academy sites, and then other site visits. So we have a team at the TA Center that are very engaged in conversations with all of these entities in terms of ensuring that they get the care they need. Next slide. So today's webinar is an important one, and the objectives I'm sure you saw in our earlier advertisements, but our panelists are going to provide an overview of the research that explores the connection between TBI and behavioral health challenges. We're going to talk about some risk factors related to TBI, and I'm sure along with that, what are some preventive factors in terms of further deterioration. We're going to look at alternative approaches to recovery. How is recovery defined for this population, and what does it look like? And we can talk then about steps that providers and families and peers that can take a look holistically at the interrelated health issues that come along with TBI and other conditions. And finally, our presenters will be providing suggestions and resources and best practice approaches that all of you can use to support the resiliency and recovery of this very special population. Next slide. We understand that this webinar is important to us, but we know it's really important to all of you because we want to make sure that we understand the connection of TBI to other behavioral health issues so that we can be assertive about identifying, treating, screening, and supporting recovery appropriately for this population. Next slide. We have two distinguished presenters today. The first presenter is Dr. Lisa Brennan. Dr. Brennan is the director of the Veterans Integrated Service Network, referred to as a VISN, number 19, Mental Illness Research Education and Clinical Center. She's also a professor of psychiatry, neurology, and physical medicine and rehabilitation at the University of Colorado Anschutz School of Medicine. So please join me in welcoming Dr. Brenner.
Hi there. Thank you so much for this invitation. Next slide. I'll be talking today about traumatic brain injury and negative psychiatric outcomes. I'll be focusing specifically on veterans and military personnel, though I will be using some civilian data and literature to highlight areas that we don't maybe have complete data on veterans yet, but that do outline problems that we think are similar amongst veteran populations. Next slide. I should say everything that I am going to say today is all me and not the VA. Next slide. And it always, I think, helps me get grounded when I think about, what's it like to live with a brain injury and how do we help people have better lives. So this is a quote from a veteran who was in one of our studies, one of our qualitative studies, said, "I think it took a while before I realized, and then I started thinking about things and realizing that I was going to be like this for the rest of my life. It gives me a really down feeling and makes me think, why should I be around like this for the rest of my life?" And to me, this just highlights the fact that we as a community need to keep working on ways to create meaning and create good lives for people post-brain injury. Next slide. So in terms of injuries from the recent conflicts in Iraq and Afghanistan, I think we all had heard a lot about blast injuries. And blast injuries, people use terms like IEDs. They really can give you a brain injury in multiple different ways. So the different ways are, as you can see in this picture, there's a blast wave emanating off of it. That itself is believed to be not good for brains. People can be thrown by these blasts. They can also have shrapnel and things from the blast hit them in the head and in the brain. So multiple ways to get a brain injury by blast. Next slide. The other thing to keep in mind, I think you need to click 3 times for this one. There's 3 pictures. There you go. So people, thank you. People are also engaged in other activities that just general duties that also can result in brain injury. So people do get brain injuries from everyday things, just like in the civilian setting. So car accidents, maybe not in civilian settings, jumping out of airplanes. Next slide. Just to make sure that we're all clear, a brain injury actually is a historical event. It's something that already happened. and it has two key components. It's a bolt or jolt to the head or a penetrating head injury, so there's the injury and the associated alteration in consciousness. You need those two things together to have a brain injury. Not all blows to the head result in a brain injury. You can have a head injury. And the severity of such an injury really ranges. So it can be mild, so that you feel like you have your bell rung, to a persistent vegetative state. That would be a much more severe injury. And TBI, depending on the severity, can really result in long-term problems with independent function. Next slide. So we classify brain injury by mild, moderate, and severe. I'm not going to go too far into this, and I know these slides will be made available to folks post this presentation. But really important to think about what we do is we rate severity of brain injury not on the impact of symptoms or on the impact of functioning after, but really on the disruption of brain functioning at the time of injury. So how long was your loss of consciousness? How long was your alteration of consciousness? Were you able to lay down new memories or not? When you're not able to, that's called post-traumatic amnesia. And so we have, and I'll talk about this more, but you can sometimes have folks who have a mild TBI that have very severe headaches. Their symptoms can be severe, but their TBI is mild, and that's confusing to lots of folks. The other thing to remember is that the vast majority of brain injuries are mild. 80% is the number we kind of talk about, and that mild TBI and concussion are synonymous. Those mean the same thing. Next slide. In terms of worldwide numbers, so this is numbers of individuals who actually served in Iraq and Afghanistan and in the military that sustained brain injuries. As you can see here, it's 82% is mild, and then you see that they have severe and penetrating in their own categories. Those would both be considered severe. What is important to note here, so this grand total here is about 400,000. Next slide. That 400,000 probably doesn't account for individuals who sustained brain injuries that didn't get medical care, or got brain injuries and didn't really realize that they got a brain injury. They were really in the middle of a firefight, or they were out somewhere in theater and either didn't have access, didn't have time, or it was before the time that we were really doing a lot of brain injury screening at the beginning of the war. So this was a study we did some time ago now during a pretty heavy period of combat and high tempo, and about 23% of the individuals in this brigade combat team had a clinician-confirmed TBI when they came back. So the exact number is something I think we will never know, and we're still trying to figure out. Next slide. I mentioned this already, but common mild TBI symptoms should not be confused with the injury itself. So you cannot use symptoms to diagnose brain injury, nor can you use symptoms to diagnose the severity of brain injury. TBI is a historical event. Next slide. So common mild TBI are post-concussive symptoms: headache, poor concentration, irritability, fatigue, anxiety, dizziness. Most people have these after they have a brain injury. People often talk about, like, I had the worst headache of my life. I couldn't concentrate. I had trouble kind of attending at work, looking at my computer. If you're in a more civilian setting or even in a military setting, you could be. With most people kind of returning to baseline functioning within a year. I should note that the vast majority of our literature and our research on TBI has been related to one injury. We are not as smart as we could be. We are not as smart as we could be about how to prognosticate about multiple injuries, and we are not as good at understanding how injuries plus comorbid mental health disorders lay on top of each other. Of course, both of those things happen in the brain, and they are both biologically driven, although sometimes we think of mental health as a mental health disorder and TBI as a physical disorder. I actually think about them as being very similar, both happening in the brain. We are not as smart as we could be, and we need more research and researchers to do good work to help us figure this out. Next slide. So this is some data we collected at Fort Carson. You'll see those symptoms that I already talked about. And what we used here is headache, dizziness, balance problems, and we asked when they came back, right, post-deployment, what symptoms did you have right after your TBI, and what symptoms did you have, do you have now? And what you can see here is most of the symptoms going down as we would have expected, except for irritability and memory problems. Irritability, and memory problems. Next slide. And then we asked it a different way, and what we really started to see here is a decrease in what we would call post-concussive symptoms, the headache, dizziness, balance problems, and then an increase in post-traumatic stress problems. And so this idea that these symptoms are overlapping, that they may lead one into the other, is something we'll see over and over again in terms of our veterans and really civilians also returning from civilians who've maybe been in accidents or other traumatic situations in which they got brain injuries. Next slide. This is a little bit hard to see, but what basically you have here is what we did is a 3-month follow-up study on these folks, and we asked them what symptoms they still had. What's in the box on the left-hand side on the bottom, which you can look at in more detail, is basically what it's showing you is if you have a TBI alone, it impacts your functioning, it impacts how severe your symptom reporting is. If you have a TBI plus PTSD, it's worse. And what you'll see on the right-hand column are more mental health-related symptoms that we don't often associate with TBI, particularly persistent TBI that's going on for a long time, high reporting rates of mental health problems, mental health symptoms, in those with a history of TBI, much more in those than those without a history of TBI. Next slide. And we also know that this is, I'll try to point out when it's mild, moderate, severe TBI, or when it's civilian military. This is a civilian study that was done in psychiatric emergency in Australia. Richard Bryant, what he did is they looked at new onset psychiatric conditions post mild TBI in the emergency room. Again, these are not conditions that had ever occurred before in these folks, and 31% reported a psychiatric condition in the first year, 22 developed a new onset psychiatric condition. Also, the most common are, you'll hear these again and again, depression, generalized anxiety disorder, and post-traumatic stress disorder. Next slide. So just a few words on TBI and depression. These are all, this next series of slides are all from civilian settings, just so you know. Next slide. And what this is basically a paper from Harborview Hospital in Seattle, our colleagues there at the University of Washington. They looked at depression in the year post hospitalization. The majority of these folks it was actually a mix of injury severity, but what they found, you did need to be hospitalized though, so that gives you some sense. They found that about 50%, a little over 50%, met criteria for depressive disorder, so major depressive disorder at least once in the year after injury. Next slide. And what they found, which I think is really interesting, is it's not right after the injury for folks. That for some folks it was at 1 month, 2 months, 3 months, and you can see this cumulative growing percentage of individuals that have brain injury. And so, if we are in a system of care where we do have access to folks, asking on the way out the door is probably not enough. We need to find ways to ask or coordinate with primary care to ask even up to a year post-injury, and probably longer than that. Next slide. The next 2 slides are from data from the TBI model systems, and they are of folks with more moderate to severe TBI. And what we found is that individuals who were 1 year post-discharge from TBI model systems had both major and minor depression, which means that they went home and then they were still reporting depression 1 year post. About a quarter of individuals still having depression that persisted. Next slide. And then this is 2 years out, that 3/4 of those with major depression at 1 year had clinically significant symptoms at 2 years. And so again, this idea that people are having depression in the first year, during the first year post, we've seen that in 2 different studies, it's not being addressed, and then they go on to continue to have depression. The depression was associated with poor social support, pre-injury mental health issues, and including substance abuse, which I'll talk about in a bit. Next slide, focus on PTSD. Next slide. So, in my office, what I started to see was folks come in and say, Lisa, I've got attention problems, I've got headaches, I've got, irritability, anxiety, maybe I have flashbacks, but I definitely have some nightmares. Can you tell me which symptoms are associated with which condition? And what I basically say to them is, No, I cannot. We are not able to do that yet, and these are both, as I said before, happening in your brain. Flashbacks are not associated with TBI, so if you have those, that pretty well goes in the PTSD category, but other than that, it's very challenging. Next slide. And I think really much more realistic. At Fort Carson, when we were there, we did timelines, and this is an example of one of the timelines where an individual is deployed to Iraq, they're exposed to a traumatic stressor, they sustain a mild TBI, they have post-concussive symptoms, so headache, irritability. They return to the United States. They're still experiencing those symptoms, which seem to be getting worse. They're diagnosed with PTSD. They're treated with medication, and then they're redeployed. And so you will see, people are still in combat situations now, and unfortunately, there is morbidity and mortality associated with that. And I saw somebody died over the weekend in the Persian Gulf, and this was his 9th deployment. So he was killed in combat. And then what we have are folks having suicide attempts in theater or when they come back. Next slide. We do know that there's increased rates of PTSD in those with mild TBI. So there is something that seems like about getting the injury makes it you about twice as likely, or there's been different numbers that makes you more likely to go on to develop PTSD. Next slide. And we found that also in individuals who had both mild TBI and PTSD, both symptoms were independently associated with post-concussive symptoms, and those with both conditions were at greater risk of having more symptoms. So I'll show you some examples of that. Next slide. Here's any symptom, and this looks kind of nice, but it goes like we would expect it to. If you had both, you had 6 times more likely if you didn't have mild TBI or PTSD of any post-concussive symptom. Next slide. But here's what I want to highlight, headache. Headache we often think about as being a TBI-related symptom. So if you had TBI, you were 4 times more likely than if you didn't have TBI or PTSD. But if you had PTSD, you were 3 times more likely. And if you had both, you were about 6 times more likely. Next slide. Here is dizziness. We don't often think about dizziness being associated with PTSD. We think about it more as a TBI symptom, but here you're 4 times more likely to report dizziness if you have PTSD, which is more than if you had concussion. So just trying to help ourselves break out of the trap of thinking about these symptoms as belonging to one condition. They are non-specific, which is part of the problem. Hence, we're finding them in both TBI, PTSD, in both. Next slide. Here's memory problems. Same, 4 times more likely if you have PTSD alone. Next slide. Balance problems, 5 times more likely if you have PTSD, about 13 times more likely if you have both. Next slide. Irritability, same patterns. Okay, so I'm saying this to you to kind of highlight that our ability, that we know that you have higher rates of PTSD, but our ability to parse these symptoms and put them in nice categories is really limited. And the other thing I should say about that is that not only do we have a hard time doing this, our veterans have a hard time doing it. And I don't have time to show you a different study today where we asked veterans, which symptoms do they think were associated with psychological exposures versus physical exposures, and they had a very hard time doing so. And we do too, so I think we're all in that together. Next slide. So substance abuse, just a few slides to highlight the impact of TBI in military and veteran cultures. Next veterans. Next slide. So this is a study done by Rachel Seiko-Adams. I talked to her this morning, told her I'd be presenting this slide. So she's doing some really, really important work around substance abuse. And basically, you can dive into this data, but what she found here is that those with a history of TBI versus not TBI among active duty military personnel were more likely to engage in binge drinking behavior in the year post-combat. So next slide. Also, here's opioids, and we know there's a huge opioid crisis in America. And basically, here we found that veterans were more likely to misuse opioids and have problems with reintegration if they had a history of brain injury. So again, this idea of linking things that we traditionally think of as physical health, mental health together. Next slide. And perhaps most importantly, all this is impacting functioning. And these folks, this is from our colleagues in Boston, they looked at kind of different ways of breaking these symptoms apart and then putting them back together. So they talked about, a mild TBI, depression, and PTSD, and called that a deployment trauma factor, pain, sleep, anxiety, PTSD. And what I think just is really important for us here is this idea of grouping physical and psychological together into one whole health way of thinking about somebody, and then looking at how these symptoms impact function. So what they highlighted in this study is that those who had the deployment trauma factor, so that is depression, PTSD, and TBI, were more likely to be substantially disabled than individuals with depression and PTSD but no mild TBI, no concussion. So you remember at the beginning when I said we're not really that smart about how adding a TBI on to things that we know a lot about changes it. Here's one example of how it seems to change it. About 3 to 3.5 times more likely to have substantial disability if you add that TBI on. And their conclusion that depression, PTSD, and history of military TBI may comprise an especially harmful combination associated with high risk for substantial disability. That being said, we do not think of mild TBI, one mild TBI alone, as contributing to substantial disability. If I could see you all on the line and we had you all raise your hands and say, who's had a concussion before? A lot of you have. And we're built for concussions, but it may be that a military-related concussion, and I have other data that I'm not showing today about the fact that likely this is not these individuals' first concussions, plus depression and PTSD really can be problematic for folks. All right, next slide. And when we think of outcomes, we think about kind of the worst negative psychiatric outcome is suicide. This is what I do a bunch of my work in, and so as you can see, fairly recently, and I highlight the numbers up the left-hand side, 0, 20, 40, 60, so these are in the tens. Almost no work done on this recent to the previous conflicts. Happy to kind of let people know that this continues to grow and grow, and there's more groups doing work in this, including, if you're interested in this, there was a very large JAMA study that just came out last week or 2 weeks ago about TBI and suicide, and they were able to use a very large European sample to look at this question in a way that nobody else has because they had such a large data set. That's civilian data, so I'm not going to present it today. I'm going to present a study that we did a while ago that we're in the middle of replicating. Next slide. So really the seminal article on this was done in Europe some time ago now, 2001. And what they found is that, mild, moderate, and severe TBI increased your risk for death by suicide, and that they found that the risk of suicide post-TBI was consistent and continued for 15 years follow-up period. To highlight here, they only looked at a 15-year follow-up period. So 15 is not the magic number, it's just when they stopped collecting data or stopped having data. I think what is really important to note here is it may not be, particularly in civilian populations, that the underlying etiology is the same, but in terms of people with mild TBIs and risk for suicide and moderate to severe, but we don't know yet. So what I mean by that is perhaps for mild TBI or concussion, and I'm not talking about sports-related concussion, but let's say you're an individual engaging in risky behaviors and getting in car accidents and getting in bar fights. If they're engaging in impulsive and risky behaviors, we also think of suicide as an impulsive and risky behavior. So maybe mild TBI and suicide are on a similar pathway for some people, versus more moderate severe injury, we really think maybe it's more associated with loss of reasons for living, mood-related problems, and challenges transitioning to having a meaningful life and making meaning post-injury. But those are all research questions that I cannot tell you the answer to yet. Next slide. So we replicated this study some time ago now in veterans, and again, as I highlighted around it's a Danish study, we need a ton of records to be able to do this kind of work. We needed 8 million records to be able to do this. Next slide. And basically what we found is mild, moderate, and severe, and here we controlled for psychiatric symptoms. As I've already been saying, we know psychiatric symptoms are increased after TBI, so we took some of our power out and just wanted to look at injury alone. And again, we found in all severity levels, TBI history was associated with death by suicide. Next slide. And you won't be able to see, well, actually you can see these pretty well. What I want to really highlight here, what you've got is those who died by suicide with the TBI and those who did not die by suicide. And you see these just very high rates of psychiatric conditions in both of these cohorts. And what you have at the top is more what we think of mild, and at the bottom, more severe. And so getting back to this idea that we have very high rates of untreated psychiatric conditions, people living with psychiatric conditions with the TBI, that we are not sufficiently addressing in our current strategies for treatment. Next slide. Which brings me to intervention. I'm going to focus specifically today on psychological interventions. Mostly, I'll touch on one thing because I'm a psychological interventionalist. So next slide. I want to highlight here that we often really wait until people are in crisis to intervene, and that's way, way downstream, right? So that we know that individuals are indicated populations. Certainly, if you have a history of TBI and depression, you are way downstream. But what are we doing upstream when people maybe before they develop depression, or maybe when they have a minor depression, or maybe we know they're having sleep problems? What are we doing upstream to intervene with folks with a history of TBI so that we can really not get all the way downstream to where we're intervening when people are in crisis? And we are not doing enough on whole regarding this, TBI, no TBI, but this is something really important to think about. Next slide. The other thing, John Corrigan and Flora Hammond have both written beautifully about particularly moderate to severe TBI being a chronic health condition. And in a chronic health condition, what are we doing to promote health? So health promotion interventions to decrease secondary negative health-related outcomes that result in that could be psychiatric conditions, but then also result in psychiatric outcomes that we are trying to not have as many of, like suicide. And really, so just flipping this whole thing on its head and thinking, what do we need to do upstream, and then what do we need to do downstream? Next slide. This is a systematic review on depression. If you could read the small print, what it would say to you is we have very limited evidence about how to intervene. You should use medications that you would use for depression in general, but it is very hard to do these studies, and there is some evidence for both CBT for depression and antidepressants, but limited, both. Next slide. One of my colleagues, Graham Simpson, really has been leading work in this area for a while, and he found that 35% of those with TBI endorsed moderate to severe hopelessness post-brain injury, and this was 1 to 10 years post. We know hopelessness is associated with depression and many other conditions. We also know it's a better predictor of suicide than depression itself. Next slide. So Graham did an intervention called Window to Hope that was a positive intervention, which means it worked. Next slide. And basically what he thought is if you get a TBI, we know there's high rates of hopelessness, which leads to ideation and suicide attempts. Next slide. So this is a group treatment. I'm not going to get too into the details. They're small groups focused on CBT skills, problem-solving skills, and post-traumatic growth. Next slide. And lots of mnemonics and strategies to teach these skills. This is like not rocket science interventions. If you're a psychologist, you probably know how to do a lot of these things. That being said, it is a manualized treatment with a very specific process and very specific repetition and instructions. Next slide. And we replicated this in the U.S. We got funding from the Military Suicide Research Consortium. You can go 2 more slides up. That's the consort diagram. Want to show you we were really, really specific about who we recruited, so it was really hard. We made sure that folks actually were hopeless, so they had room to change in the study, and they had moderate to severe TBI. Next slide. And what this is just to show that I was obsessed, as the team was too, of making sure that we not only had significantly, statistically significant change, but clinically significant change. And so we were really focused on these cut points for these measures like the Beck Hopelessness Scale. We wanted to see if we could really help people move to a clinically meaningful, less hopeless space. Next slide. And so what we found was statistically and clinically significant findings from our trial. Just so you know, this is the first randomized clinical trial that I think has ever been replicated of a psychotherapy for folks with moderate to severe TBI. So super proud of it, and super excited to let you know that folks with moderate to severe TBI can totally benefit from psychotherapy. So if you don't remember anything else today, please remember that. They may need you to slow it down. They may need you to repeat. They may need smaller groups, but they absolutely can benefit in a clinically meaningful way from interventions. Next slide. So I also am very interested in things that executive functions, so ways of thinking, ways of problem solving that might contribute to suicide risk in this population. And basically what I'm showing here, if there's psychologists or folks familiar with the Iowa gambling test, what we found is if you have a TBI alone, you do okay on the Iowa gambling test, you learn. But if you have a history of TBI and a suicide attempt, you actually just don't engage in the task, which is really concerning because we don't want people to stop engaging and trying when they are feeling suicidal. We want them to keep trying new strategies and problem solve. And so that flat line at the bottom is the group that had, on the right-hand side in the figure, is the group that had suicide attempts and TBI. Next slide. So you can see I like to think about mechanisms. So here's TBI that results in cognitive deficits. Again, moderate to severe TBI, hopelessness, you have a stressful life event, you have internal distress, failed problem solving, which builds on itself, and that you think suicide is the only problem, you have trouble engaging in problem solving, and then you make a suicide attempt. So we have a second intervention that we developed, next slide, that's focused specifically on problem solving therapy, dealing with emotional regulation and planful problem solving, and also safety planning. If you're not familiar with safety planning, it's an evidence-based suicide prevention intervention. And so what we do is use the safety plan to facilitate teaching around problem solving. Next slide. Also a group intervention focused on problem solving skills, triggers, warning signs, strategies, lots of strategies, brainstorming, really, again, not rocket science concepts, but really presenting them in a way that makes sense to folks, lots of visual aids. Next slide. So here's an example of one of the worksheets. This idea that if you have stress and you have problem solving abilities, you can handle it. But if you have too much stress, it can break your problem solving abilities. So you need extra bolstering. And that what we do in this group is bolster. And you can see those little bolsters for the problem solving skills. This we only did, next slide, you'll see we only did a feasibility and acceptability trial, so I can't tell you if it actually works, but I can tell you by the next slide that veterans really like it. So they all found it to be really great, and I have qualitative data too. They stayed in it. I should say for both of these groups, we've had really good attendance. We do lots of reminders and stuff, but folks come and they benefit. So one of my jobs is to write an RCT for problem-solving therapy for this cohort. So that's on my to-do list. Next slide. Also good data to show that evidence-based psychotherapies like CPT and PE work for folks who have TBI. So just because you're working with somebody who has a TBI, don't think they could not benefit from therapies that we already know that work. And folks are doing more and more writing on this. This is Greg Wolf and the team in Florida who did this, Orlando did this study. Next slide. Also really important to think about other maybe talking interventions that could help. So we have a yoga-based trial right now that we're doing for veterans with mild TBI and post-concussive headaches. Next time I present, I hope I get to show you some data on this. But this is a study that we've got underway using yoga, physical postures, mindfulness, and really hoping to help people with their headaches with this. So more to follow on that trial. Next slide. And we know that there's a lot out there and there's a lot changing, so we've developed a toolkit primarily for mental health providers, but for everybody, really, that is focused around like TBI 101, mental health and TBI. It has a new section on justice-involved individuals, a section on military and veteran culture, and resources. I should also say under the TBI section is a whole pediatric section. Next slide. So if you want more information about kind of some of the stuff I've presented today, some of it, not all of it's presented here. There's separate sections. So here's mental health that has substance misuse, depression, PTSD. It has resources. We wanted folks to be able to use this in their offices, so everything we've put in here actually is like free and downloadable, and you can use it like when you need it. Next slide. And the last thing I want to say too is if you are not familiar with veterans or you don't know about military culture, that's something that you can spend more time on. I think of it as a diversity issue. Spent a long time in the VA and learning about military culture, and I want to be smart about the things that I'm asking my patients about, their experiences, what it's been like, where they've been. And so if you're working with veterans, like there's lots of resources, some of them here, that you could be smarter about military culture. Next slide. Again, from one of our vets, what do you do when you're feeling suicidal? Talk to a professional. That's why you guys are here, trained to deal with people with my problems. Left to myself, I'd probably kill myself, but that didn't feel right, so I turned to professionals. And I guess I would say that the most important thing is that professionals, like all of us on this line, and folks out in the community and in the VA, we need to know how to help folks and have the tools so that we can do so. Next slide is just my contact information. I'm on Twitter, love Twitter. So if you're on Twitter, love to hear from you, and that's what I have for you today. So thank you.
Well, thank you very much, Dr. Brenner. That was really compelling and a lot of good information, and I know that there will be some derivative questions that people may want to get to at the end. So, again, thank you so much for your incredible experience and a lot of good, solid information. Now I'd like to turn to our next presenter. This is Gregory Ayat. Greg is the Director of Consumer Services from the Brain Injury Association of America. Welcome, Greg, and you're on next.
Excellent. Well, thank you very much. You can just move to the next slide. It seems funny to look at my face. Again, I'm the Director of Consumer Services for the Brain Injury Association of America. Before coming to the Brain Injury Association, I had worked in a brain injury community reentry program, and since coming to the Brain Injury Association, I've worked on the National Brain Injury Information Center, answering questions that come to us from all over the country, so covering every issue from concussion to coma to substance abuse. Next slide. This is just the Brain Injury Association vision and mission statement. Next slide. This is the crux, I think, of one of the questions we have been asking at the Brain Injury Association. I think what a lot of folks struggle with is this question of how much rehab, in what setting, and at what point after the injury is not an easy question to answer. And in part, it's because brain injury lives in two worlds. You have the immediate care after the injury, which is measured and measurable and tends to be pretty time limited. And then you have the part where there's continued recovery after discharge from any type of rehabilitation setting. And that part handles the social skills, decision-making, problem-solving. That part is obviously much harder to measure, which also makes it harder to get funding or supports for interventions. Next slide. So we get requests from all over the country. And one of the common challenges we hear is that there's reduced time. This is more for civilian than for military, certainly. But there's been a reduced time for rehabilitation regardless of the civilian funding source, which kind of creates its own additional stressors. So one of the things we know is when I first started in brain injury, it wouldn't be uncommon for someone to be in rehab for easily 60 or 90 days before coming to a community reentry program. And now the data shows that most people are staying in rehab for no more than 3 and 4 weeks at a time, which creates a lot more stress for the family. So they're dealing with a quicker transition process, they're dealing more with insurance issues, and the staff don't have as much opportunity to educate families about brain injury and what that might look like. So, because there's a process that families go through to start to understand brain injury and what the impact and implications are, and the time frame that they have to do that with the support of professionals is much more limited now. Next slide. So it's a little bit about what the Brain Injury Association is doing, kind of big picture, little picture. From a big picture standpoint, we've been working on guidelines for post-acute care. So there's not really any guidelines to say what type of rehab in what setting. So we're trying to answer that question, reviewing the rehabilitation literature and developing some evidence-based guidelines for structure, for some direction. In addition, from a more direct standpoint, we offer education for families through our website and through our 800 line. Folks can contact us to get information on a range of issues. And we do a lot of continuing education for professionals, both through our certification program for folks working in brain injury. We also have webinars for families. And, of course, as a national advocacy organization, we do a lot of federal advocacy efforts for increased funding for research and services in brain injury. Next slide. So I was asked to kind of share, what are some of the helpful resources and informational supports that I thought could be helpful. And so this Ohio Valley Center for Brain Injury Prevention and Rehabilitation is really one of the better resources that I'm aware of, specifically about substance abuse and brain injury. The Ohio Valley Center has been a brain injury research center for many years, and one of the areas of their research over their years has been substance abuse and brain injury. So this is just one small section. You'll see a few more slides in my presentation. So there is a ton of information on this website for both providers as well as for family members. There is information on here for providers about screening tools you can use in your program to help identify folks with brain injury. There's information about brain injury, a web-based training module that providers can use, and there's a lot of information for families as well to educate them about brain injury. Next slide. And there's one thing I hope to convey. It's that this idea that brain injury is a long-term issue. So this is a graph of a breakdown of the time after an injury when folks contact the Brain Injury Association. It's a little small, but you can see over a quarter are 10-plus years post-injury when they're contacting us looking for information about support or resources. And I think too often folks think about brain injury as a singular event where you get hurt, you go get help, you recover, and you go home. And that simply is not always the case. That very often brain injury creates lifelong changes, not only for the person with the injury, but for the family. Next slide. So this was a slide that I pulled when it really surprised me, in that we looked at the requests for information and resources, so what people were asking for when they contacted us. And these have been pretty similar, I'd say, for the last several years. And the type is a little small, but substance abuse is not listed in the top 10 requests. And that really surprised me. So we know that substance abuse issues and brain injury, there's a big overlap, and it's a big issue. So we started to delve more into the call notes, and we reached out to folks who had contacted us, and we realized a couple of things. One is the substance abuse issues were wrapped up in some of these other things, like caregiver family coping, mental health issues, behavioral issues. The people who were contacting us looking for information about that, but the real issue was the substance abuse issue. The other thing we found was when we contacted some folks and did follow-up and asked them if there were substance abuse issues involved, a lot of them said yes, but they hadn't asked about it. And so one of the things that they shared was that they felt like since they were contacting a brain injury helpline, that everything they should ask was in relation to brain injury. And it certainly made me realize that all too often we kind of live in our own silos. And so it's important as brain injury providers that we are asking questions about the substance abuse history, kind of what has been their history and what they're doing now. but also it's important for mental health providers to be asking questions about the history of brain injury and how that might impact the treatment. Next slide. So one of the other things that we have are working on to help with the education piece is later in the fall we are rolling out what's called the Brain Injury Fundamentals Program, and it was designed as a primer for brain injury. It was originally designed as kind of an introduction for folks that are working in the field of brain injury, as well as for families that might take on some type of a caregiver role. We had found that it also could be helpful for providers that might work with some cases of brain injury, but not necessarily, that's not all of their workload. So certainly you can check the brain injury website. You can certainly reach out to myself if you're looking for more information about that as a resource. Next slide. Again, we come back to the Ohio Valley Center. Again, I would say that this is probably one of the better resources I can think of when it comes to brain injury and substance abuse. So this is more information more for families. And one of the nice parts about this is it talks about both brain injury recovery and substance abuse. So it talks about, one, the interaction of brain injury, substance abuse on brain injury recovery, and it also talks about the issue of substance abuse separate from brain injury. I think it's a very helpful tool. You can go to the next slide. And so this is the other section of it, this user manual, information for individuals and family members. This user manual helps folks to understand kind of what the recovery process might look like. I think one of the biggest challenges for families is understanding the time frame for recovery, that most of the folks, a lot of family members don't understand how long a recovery after a brain injury can take, and so that in and of itself can create a lot of stressors both for the family and for people with brain injury. Next slide. So this just some other suggested resources. Again, we have our 800 number. So that connects with not only the national office, but with our state offices as well that have information about brain injury for families. We'll have information about local brain injury supports or resources, and we'll help direct folks as best we can. Next slide. So the last thing I think I wanted to kind of share is we had mentioned before that the biggest challenge that families face is that timetable for recovery. That's a really hard concept, I think, for folks to be able to wrap their heads around and to be able to accept. And so how the family recalculates their expectation will go a long way to how things will be managed. We often tell families that we talk to that the brain injury recovery it's a marathon and not a sprint, and that it's important to kind of manage yourself as well as whatever caregiving roles you might be taking on. Another factor is that we always tell folks that self-care is as important as caring for others, that a lot of times that caregivers kind of underestimate the toll that caregiving might take on them. Additionally, when we are talking to families, one of the things we consistently ask about is kind of, how are they assisting the person with the injury? And we often will hear from families that they think of caregiving as only helping with like bathing or dressing or some kind of physical assistance. But very often the caregiving assistance for people with brain injury is more along the lines of planning and organization and decision-making and helping them think through kind of what some of their processes might be. That in and of itself takes a toll on the family, and I think sometimes that they underestimate that impact and the need for some type of support as they kind of manage both the household as well as the caregiving duties. And then the last thing we try to share with them is how common or how often brain injury happens. I think part of the challenge is after brain injury, the initial recovery, folks scatter. So it's always, you can feel very isolated and very alone, and it's important to understand that you're not the only person going through this, that there is some help and support out there, and that the recovery time can take a lot longer than expected. So I hope that has been helpful information. I'm always welcome to answer any questions that folks may have.
Well, thank you very much, Greg. And I know that we're going to go back to the National Council staff, and we're going to see what kind of questions there might be for our presenters. So I'll turn it back to you.
Great. Thank you so much. So I just want to open it up. We have had people writing in questions during the presentations, but also just, prompting everybody who's on the line, if there's additional questions that you have that have not come in yet, now's the time to send them in because we're going to move into the Q&A portion. I'm going to start off with a question for Dr. Brenner, although Greg, you might also be able to weigh in on this. Considering the data you reviewed regarding TBI and suicide, is there any sort of, clinical standards or guidelines around early identification in the format of, suggested regular screening for depression or suicidality for people with TBI?
So, there's two kind of different parts of that I'll answer. So there are not national standards for TBI in specific that I know of. Greg might know something else. For depression or suicide. Now, that being said, I can speak to the VA is now implementing, actually in the process of implementing national screening for suicide. We already have national screening for depression in primary care, but we are now going to be doing a 3-step screening process for suicide, and one of the mandated settings is inpatient rehab. And so this will be, I think, a huge step forward. It's not necessarily focused on TBI, but we will start to be able to get information about these numbers and this data, and it's a starting point. So, Greg, I don't know if you know of other efforts around standards. I think everybody's saying do it. There's no standards, as far as I can tell.
Yes, that's what I know.
This is Catherine. I think also I could just add that we understand that inside DOD and across the services under the Defense Health Agency, they are beginning to look much more rigorously at regular screenings for depression and suicidality for all people on active duty before they get discharged. So I assume, Dr. Brenner, that will be hopefully cataloged in the shared electronic health record in the future.
Yeah, and I should also say that I'm actively involved with the DOD on and so this is just to keep lanes straight. I'm working on the CPGs, so the Clinical Practice Guidelines for Suicide Prevention, and there is data to support universal screening, and I think VA and DOD are both going to be out ahead on that, and because of VA and DOD databases and availability of being able to kind of look across records, I think we'll be able to get more information about how those screening efforts help us identify.
Right. Right.
Yeah. Yes.
That's great.
That is great. That's really helpful. In a similar vein, not quite the same as thinking about early identification and maintenance, but somebody asked, we talked about the symptoms of PTSD and TBI and how they are similar. And they're curious to learn more about how we can be sure TBI is properly diagnosed.
And so I guess one thing is TBI diagnosis is, I'd say, important, and particularly with more moderate to severe TBI. Back to the great resource that was presented by Ohio State. Ohio State also has some very nice resources on that same website, and it's in our toolkit also, so you can look at it in the toolkit about, evidence-based strategies for screening and assessment. But, if you're having trouble identifying history of TBI for sure or concussion for sure, one thing I just want to highlight, and this is consistent with the VA DOD clinical practice guidelines for TBI, is treat the symptoms, okay? So if you have somebody that does have PTSD, please provide them with evidence-based psychotherapy for PTSD. If you have somebody who has headaches that are persistent, please give them evidence-based psychotherapy for headaches. Same with sleep, same with any of the symptoms we've been talking about. Treat the symptoms.
Great.
I see that there's like a number of questions about justice-involved individuals. Do you want to talk about that for a second?
Yes. So, yeah, we have a lot about resources or funding assistance available for those within justice systems and, you know, challenges just with coming into the system with substance use, but also having TBI.
Yes. Greg, I'm happy to defer to or talk, and then you can join her.
Well, I mean, that's probably one of the kind of common requests that we get, and I think the biggest barrier usually is the funding. Is that's usually it, because they're coming in as, you know, under some type of either mental health or substance abuse, and to try to get them into any type of brain injury rehab can be challenging. Additionally, there's limited resources that are specific to kind of do dual diagnosis, brain injury, and substance abuse. So I think those two factors kind of can often limit what the options might be. Like I said, folks are always welcome to contact us. Whatever information we have, we're always welcome to share.
And then I guess I'll add to that. We have focused with the HRSA grant that we had with the State of Colorado Brain Injury Association, focused on justice-involved veterans or justice-involved individuals. Sorry, not just veterans. And I think it's kind of a very challenging topic. In other countries, there's been more work on this than there is here. That has clearly showed that, you know, again, TBI runs with other risky behavior, and that particularly mild, and that, you know, those with histories of TBIs have worse outcomes and higher rates of recidivism. You know, I always think about starting points and then, like, what would be penultimate. And for me, you know, individuals who are incarcerated often have many challenges. Having a history of mild TBI or concussion might be one of them. It may contribute, and as I mentioned before with veterans, it may be part of a larger constellation of problems that together are greater than the sum of their parts. In addition, there are a group of individuals who are incarcerated who have more moderate to severe injuries. I'm concerned about both groups. I'm really concerned about the groups of have moderate to severe injuries that may need modifications or may not, you know, be able to kind of adjust as well to the system that they're in. And then particularly when those folks are discharged, just because of funding, there's what we found, and we did a bunch of qualitative interviews in Colorado, is that there's just not a lot of resources to help those folks transition. And so if you have, and we know that there is a huge relationship, and we've done some work around this too, around homelessness and TBI, outcomes amongst homeless who have TBI are worse. And so my concern is that, particularly for those with moderate severe injury, that we have this cycle of not enough resource to transition, and then becoming homeless, and then getting more TBI, and then ending up incarcerated again. And so really needing to think about how to help these folks transition into the community.
This is Catherine. I think also I noticed many of the questions related to criminal justice involved individuals. I think that there are some good resources and some good programs that we can send you. The first is the GAIN Center, which also belongs to PRA Incorporated, which is where the Service Members, Veterans, and their Families Technical Assistance Center is housed. It's also where the GAIN Center is housed. And the GAIN Center is another TA center funded by SAMHSA that talks about engaging from a diversion standpoint, from a sequential intercept model standpoint, about diverting people and gaining access to appropriate services to keep them in treatment and not incarceration. And so the GAIN Center, I think, is another resource. Plus, there are several veterans courts that are funded by SAMHSA and by the Department of Justice relative to trying to screen for appropriate injuries relative to those conditions that might be contributing to their criminal justice engagement. So there are some other resources besides the ones that I've already heard mentioned that we can make sure we give to you.
Yeah, and just to mention, too, that the VA does have a whole justice-involved veterans program and can provide some of that transition and facilitation. So if you have a veteran that you know is incarcerated, that is one of the things the VA really does great at. And make sure you know who your justice-involved coordinator is.
Those are a lot of great resources, and we can be sure to send out more information post-webinar. Similar to that vein is a question around, in addition to what we were talking about, is there any clearinghouses for evidence-based treatment for TBI?
Not that I know, but it's a great idea.
I think we're generating a lot of great ideas on this webinar. Another question that we have, Greg, I'm actually going to field for you, is around information you can find for local TBI support groups. Sure. And if there's anywhere that you guys have available or others could go through to find information around that.
Sure. So most of our state affiliates, on their website, they'll list the brain injury support groups that are happening in their state. So that's the first place I would look. You can call our 800 number to find information. And then the other resource that we've seen some folks use, because I know sometimes getting to a support group can be problematic. It might be transportation issues, they're in a rural area. And we found more folks developing and moderating like online support groups, like some closed Facebook groups that are moderated either by professionals or by folks who had sustained a brain injury and want to give back. So we found those to be helpful resources as well. It's not as good as an in-person support group, but certainly being able to connect with others, even online, can be helpful.
Greg, it's Catherine. Do you have a chapter in every state?
We have a chapter in, so there's the Brain Injury Association and the Brain Injury Alliance. Two organizations. Between the two, there's probably chapters in like maybe 40 states.
That would be great. One of the things we ought to do is connect the Policy Academy teams in those states with your affiliates.
Yes.
Because then there could be this connectivity about getting those individuals smarter about TBI and brain injury, getting the vet centers that might be approaching this issue on a group support level, and having the Policy Academy team be aware of that and spreading the word about it.
That would be a great idea.
Okay.
Great. So another question, actually multiple questions that have been coming in, everybody seems to be on the same page today, is really around curiosity around the longer-term impact of multiple mild TBIs or multiple TBIs in general on memory and cognition and dementia. And I'm wondering if Dr. Brenner or Greg, you could speak to that.
Multiple mild brain injuries, kind of long-term consequence?
Yeah.
Well, that's so we get that question. It's a fairly regular question. It's a really hard question to answer because brain injury doesn't happen in a bubble. So many of the lifestyle factors, how that person is managing their life can be a factor in what the long-term consequences might be. So we have that issue. So for an example, we had a phone call from a gentleman who's in his 40s, had played college football, was complaining that his memory was getting worse, and he felt like he was worried he had CTE. But as we talked to him a little bit, it became clear that he was a 40-year-old that was still living as a 20-year-old, that he was going out all the time, he was not taking good care of himself. And a lot of the symptomology that we were hearing sounded more like, well, if you kind of had better nutrition, better hydration, had better sleep, you might see some of those symptoms improve. But then there are other folks who are kind of doing everything right and have had multiple concussions, and they can see this kind of cognitive decline as they get older. So there's still so much that needs to be unraveled, or what exactly is going on. I think it's too early to know with any certainty what exactly the long-term consequences are from multiple concussions.
I mean, I can add a bit to that too. Just, I think what you see in the newspaper is way out ahead of the science. And so just trying to help people understand that, as was articulated, we are in the early days of understanding this. At present, sometimes this is really helpful for people to hear, and it's confusing, but at present there's actually no way to diagnose CTE in people who are living. This is not a diagnosis of the living. And that's how early on we are in this process. And then the other thing is that there are so many good things associated with sports, health-related outcomes associated with playing sports, being involved, being active, that we often don't take into account. And so we are just really early on in the game of understanding how many brain injuries each person can be exposed to until it becomes a problem. And part of the challenge, as Greg mentioned, is that there are so many factors that go into this, some of them being genetic. And so maybe someday, when somebody's born, we'll be able to do a blood test and say, hey, you know what, your lifetime load for brain injuries is like 15. And so we're going to try to really, you're kind of like got more than others. Maybe you should, you should do this and this and this, and then maybe not this, this, and this, versus another person who really has much more ability to not have challenges associated with more brain injuries. But we're not there. So, more brain injuries is not better, but obviously there's tons and tons of people out there who've had lots of brain injuries that are doing just fine. And so really trying to balance prevention and, certainly like in sports and, no tackle practice is awesome for football. What can we do to prevent? And then what can we do to also really reinforce that we're not where we need to be yet? And there's some very preliminary data, particularly with more severe injuries, that it can create risk for dementia, and very limited data for mild TBIs, and almost no data for multiple mild TBIs. So I'm sorry to tell you that, but that's the truth.
That's really helpful. I also think it really speaks to what you were really talking about earlier in your presentation, which is around the need for, more research to be done in this area. And there have been, a lot of questions that have come in around what kind of ongoing research is happening right now. Looking at a lot of the studies that we reviewed, they have been happening over the span of the last decade or so. And so just thinking about what do you know of any current research that's ongoing, or things that you are looking for down the pike?
Pertaining to this issue in specific?
Yes.
Okay. Well, I mean, I think that the VA and DOD are doing some good work. I mean, ideally what we would do to study, long-term impacts of TBI or mild TBIs is we would follow like a very long cohort longitudinally, right? So we would get like a whole bunch of first graders across the country, right? And we would follow them for years and see their exposure over time, and see how they do over time and how their brain injuries, if they accumulate brain injuries, what are the other factors that may impact, and then how that's related to outcomes. The VA and DOD certainly have been doing some of that work, and there's something called the CENCE, I'm not going to remember the acronym, but if you look it up, CENCE, they've been looking at some of that over time. Army STARS has also been looking over time at not as much TBI, though they do have TBI variables at suicide. And then there's another very compelling NIH, I think it's NIH-funded study, I'm sure it's NIH, it's called ABCD. They also have an awesome website, but ABCD is, they're following, I want to say starting 9 and 10-year-olds, but I'm not totally sure, but it's like that, 9 and 10-year-olds, and following them over time, looking at substance abuse and traumatic brain injury and lifetime exposures. So those are some of the big ticket, really exciting studies that are starting to look at this over the course of lifetime, which will give us the answers that we need. Kind of like the Framingham study for cardiac disease.
Great. And I think on the flip side, we have some comments coming in around various projects and programs that are being run across the country that have been. Sorry, Dr. Brenner, did you have something to say?
No, I was saying great. If there's other folks who are collecting data that we don't know about, that's awesome.
Yes, so we'll be sure to be relaying all of this information internally so that we can have you guys connecting with them as well.
And this is Catherine. Also, I'd like to just add my own thoughts. I was intrigued by Dr. Brenner's comments around hopelessness, and one of the things that we've talked about at SAMHSA is that for substance use disorders, addictions, and mental illnesses, we find that the presence of hopelessness is one of the conditions that is one of the most difficult to overcome relative to improving, the chances of recovery. And when Dr. Brenner indicated that hopelessness was a better predictor than depression for suicide, it sort of rang true for me that one of the things we need to look at more closely, and I would ask the audience as well to share resources about how do you build hopefulness into recovery support services. Very, very fundamental principle around what is necessary, and I would be intrigued to go back and look how the VA is doing it in terms of sort of positive problem solving, building a sense of the future, building a sense of hope within the context of recovery support services. And we have a recovery research institute based at Harvard and Massachusetts General Hospital, and I'm going to bring this question to them to say, what is it about, what is an evidence-based practice in which we, one, can screen for hopelessness, and also how do we build hopefulness? So I just want to raise that issue as something we might want to continue to look at over time.
And I would say in that I'm happy to share the intervention that we have evidence for, the Willard Hope intervention.
That's great.
Yeah. There is a question about TBI and violence. So, I mean, history of TBI, and I'm going to say more moderate to severe TBI in this case, is associated with executive dysfunction. And so I mentioned that briefly before. Executive dysfunction is a fancy word that we talk about to talk about higher level things that our brains do, like problem solving, impulsivity, multitasking, things that require kind of, overseeing multiple processes at the same time. And that folks with brain injury, these are thought to be housed in the frontal lobe, in the front of the brain, that is vulnerable to brain injury. And folks with brain injuries do have executive dysfunction problems. As a result, sometimes folks with brain injury have this kind of thing where it's kind of like they have a feeling or a thought and then it's out. And so sometimes angry feelings or frustrated feelings are more, front and center and out more quickly. Some folks do have really big challenges with anger and aggression, though I would say that's not like, not every person. That's like, more rare, in terms of kind of physically expressing that anger. And so, I think it is something to kind of contend with. We don't have tons of data on, the other thing that's complicating is I think the folks who have more severe injuries are probably, many of them, not all of them, many of them are in situations where they would have more supervision or more guidance. So to help not express that. And I know that's not a very, simple answer to it. And there are interventions for anger. Definitely behavioral interventions work good, and there are medication interventions. I should say on the flip side, something that we don't know as much about that we should is domestic violence and women and men sustaining brain injuries in the context of domestically violent situations. And that is something that I heard somebody talk about last year. We're doing a systematic review on it right now because I was appalled by how little I know about it and how much little is out there. But that's something else that needs a lot of work.
I really appreciate you speaking to that, Dr. Brenner. So in the interest of time, we're going to wrap up. I want to just check in, Catherine, if you have any last comments before we close out.
No, I think I just want to offer my appreciation on behalf of the Assistant Secretary and SAMHSA and the Technical Assistance Center for Service Members, Veterans, and their families, to Dr. Brenner and to Mr. Ayotte, and to the National Council for their tremendous support, for the expertise that was shared today. I certainly got an enormous amount of good ideas and was certainly educated about a variety of intricacies related to TBI and the importance of understanding it. And I really appreciate the fact that the Brain Injury Association is going to be coming out with this training program in the fall, which I think, Greg, we can make sure that all of the Policy Academy folks get it, because they're not professionals, they're not physicians, they're not necessarily members of the military, but if they can become much more cognizant of this, just in the same way that we've talked about suicide and suicide prevention as an important component of the work that we do in the states and communities, I think that the brain injury knowledge and education and screening and understanding is equally important. So I want to thank everyone very much for the incredible work that's going on. I want to thank you on behalf of all of the people who have served our country as military members and have been in uniform. And with that, I'll turn it back to you.
Thank you. So I just also want to echo that thank you for everyone who attended today's webinar. SAMHSA Service Members, Veterans, and Their Families Technical Assistance Center presents Traumatic Brain Injury Among Service Members and Veterans, What Behavioral Health Providers, Families, and Peers Should Know. We really appreciate how engaged this audience was. Once you leave today's webinar, you will receive a survey on the presentation as well as presentation slides and access to recording, and we would appreciate if you would complete that and provide your feedback within the next 48 hours. You will also receive a follow-up email by the end of the week. And on behalf of the National Council, Policy Research Associates, and SAMHSA's SMVF TA Center, I'd like to thank you for joining us today, and please enjoy the rest of your day.
Thank you very much.
Thank you.
Bye-bye now.